he had mentioned he's a specialist in community development and has had a lot of on-hand experience with this situation in Kenya. So karibu sana, Mr. Muthama.
Thank you very, very much. Ladies and gentlemen, good evening. Thank you, Professor, for such an informative presentation, and also for your passion that I have interacted with before when she comes to fighting IOM. As introduced, I run a non-profit organization named Kinga Africa. Our main focus is oral health, and we've interacted with this particular topic for quite some time now, since 2012. And it's something that must come to an end, and I feel the time is now. I seriously feel that we need to act. We need to act very fast, and we are the right people to do it. So before I get into my presentation on IOM, so it's very, very brief, I would wish to just mention in passing what we do as Kinga Africa. And after that, I'll show you some nice video clip. I call it nice because it drives the need to fight IOM into people's minds and strike some action into the same. So Kinga Africa was founded in 2012 to fight this kind of practices and also to promote oral health in our country. I would want to pull a presentation for us, and this is it. I would want to start by introducing Kinga Africa. As I had said, I said that Kinga was founded to promote oral health with various programs that we run. We are in schools every other school day. Immediately schools open, we start running our programs. We have a school health program that visits schools. We target the learners in those schools to tell them how to brush, when to brush, the need to visit a dentist, because as you are familiar with, most of us Kenyans will only visit a dentist when they have some dental pains. So we are telling them the importance of regular dental checkups. We're telling them how to brush their teeth, when to do it, with what, and other oral health practices. Our main focus is primary schools, because we believe if we teach these learners how to take care of their oral health at that age, they will grow with those habits, and that will seriously be a good thing to keep for life. So far since 2012, we've reached over 5 million children. We've distributed millions of toothbrushes and toothpaste. And we also train teachers in this particular program, because a teacher is an opinion leader in a community. Whatever the teacher says to the learner is almost law, especially the young learners in primary schools. And to the community around, the teachers around them are like the most learned people, especially in the rural areas. So if we educate these teachers on oral health, we believe that they reach out to the learners in their schools and their communities, and we are seeing a lot of change. We also distribute educational materials to the schools. Besides that, we are also organizing free dental camps, where we invite dental practitioners to come and offer free dental services to the communities who cannot access or afford dental services. So the other thing that we do, and we are very passionate about, is fighting IOM with this program that we call Action Against Infant Oral Mutilation. And what we are doing here, we are educating the communities on what exactly could cause diarrhea and why the fever and whatever other things they're complaining about would affect a child. And then we tell them that whenever they have these cases amongst the children, all they need to do is visit a medical practitioner for treatment. So that is basically the main message that we are sending across, besides telling them that teething basically doesn't cause diarrhea. So that is what we do in that program. On the same, we are also training community health volunteers. These are very key people in our community because they are in charge of several households. They do a lot of health awareness and, you know, these awareness meetings and stuff like that amongst the communities and in the households. So we train them so that when a child starts teething or when they visit the pregnant mothers and such, they tell them in advance, look, whenever diarrhea strikes, visit a doctor, visit a trained medical practitioner. Do not go to so and so, because they live within the same communities. They know the people who practice this. So we find this to be a very, very important lot to train on IOM. Besides that, we also visit mothers in prenatal and postnatal clinics in the hospitals. We have some posters pinned in several hospitals. We also visit them and you know, have talks with them. But look, this is what causes diarrhea, vomiting and fever and such. So do not go to such and such a people. So that is basically what we are doing. And in Kenya, we've worked with so many communities. We've worked in 22 counties so far. And the people who practice this, as Professor has shown us, come from mostly northeastern and central, eastern Kenya, the Kamba particularly. A child would go through this from as young as 3 months, between 3 and 18 or there, between 3 and 18 months or thereabout. They will go through all this. And as you can see, as Professor was reporting, even locally, we have several names for IOM, but they all target the canines majorly. And we've been to these communities as listed. We've talked to them and they tell us, look, this is what we do. And we do this because, you know, we found it here and we believe it cures diarrhea. Now, the other thing that I want us to ask ourselves now as dental practitioners is this question: why do we still have IOM around at such a time as this? Why is it that, yes, we've had a lot of research, as Professor has elucidated here. We've had reports, we've had papers written. Yes, people have learned and seen this even in dental practices in the country. Why is it that we still have IOM around? One of the main reasons, according to me, is that we have a culture of silence. And this culture is coming in two ways. Number one, we have the community members who are not talking about this because it's something that is helping them after all, helping quotes. They believe it cures diarrhea. So to them, it's not a problem. So they will never talk about it as such. So it's part of what they do, like buying, giving bride wealth or something. It's part of their system. So they will not talk about that. They will just keep quiet and continue with life until when they encounter knowledge from outside that what they're doing is wrong. But now, what worries me as a community development expert is the silence on the side of dental professionals. I'm sorry to say this, ladies and gentlemen, but we've had very few dentists in the forefront fighting infant oral mutilation. So far, the ones I've met, just a few, allow me not to mention names. Yeah, but I found one in Kisumu, a pediatric dentist who is very passionate about this. Professor is there, and I have two more, my board chair and another dentist in Nairobi. But now, we have dentists all over the country. We may not be very many, yes, but why are we not talking about this? So I would want to say that there is a funny scenario that I found out, which is most of the dental practitioners and the other health professionals are not aware of IOM completely. So they are not talking about it because they do not know what this is about. On several occasions, I've given a presentation with IOM on it to a dentist to present in a training, and they go, look, what is this? So that is one of the main reasons. And the other reason is that the death as a result of IOM are not counted as such in the hospitals. They'll say this child died of, say, anemia or, diarrhea, dehydration and stuff like that. But they will not relate the same to IOM. So that makes IOM just a silent killer within the communities. But for sure, this thing is taking away quite a number of children. The other day, I got a call from one of the communities we work in. This guy calls, he works with an international organization that has some WASH programs in that community. So he calls, hi, we are in a burial and we are burying a 6-month-old child whose father is actually an educated guy. I saw a question by Mohammed, whether IOM reduces with increase in education. Education per se may not reduce this. The normal academic systems going through the curriculum in Kenya and such, because this child belonged to a very educated guy, a senior man in government offices around there, but they had taken the child for IOM. After a day or so, the child was rushed to hospital, but before he got there, he was dead because of IOM. I was also sent a photo last year from Kisumu by a doctor friend of mine, a dentist. It's like, oh, we lost this one because of IOM. So IOM is killing children, friends, and we need to talk about it. Now, is IOM part of our main focus as dental practitioners? Professor has talked about that. I need not to, dwell well on it. He's talked about it already. But we need to have dentists all over the place talking about IOM. The second reason as to why IOM is still with us here is just that simple belief that IOM cures. And as I would say, in the absence of non-alternatives, whatever works in these communities that we are working with. So according to them, they take the child there. Of course, to some extent, it cures. By curing, this is what I mean. They inflict a lot of pain on these children. So because most of them, whenever they are crawling around during teething, as you may know, as you know, gums becomes itchy. So to ease the itching, these children will pick all the objects from around them and take them to the mouth. So that injection of that would cause diarrhea. But now, when that pain is put in there, they will not take in these objects and the intake of that is stopped. So if that itching per se was the cause, then diarrhea stops if the child continues breastfeeding or otherwise feeding well. So that belief alone would make communities to continue practicing this deadly practice. Now, why is this around? Reason number 3, we do not have dental services in most of the communities. Like we've been to sub-counties which do not have a single dental clinic, like Masinga, for example, in Machakos County. There is no single dental clinic in that sub-county, whether private or public. So the communities around there only know the community dentist, that is the traditional birth attendants and the other ampalists who do this particular practice. So they are the people they can access. So this is a challenge and a reason as to why we do have an increase in IOM. And then we have limited data on the same. You see, when we talk about things like FGM, malaria, and such, we've a lot of research done. We've had a lot of data collected, and we've reports and surveys and all this. So it becomes very easy to, to mobilize resources to fight IOM, and to also talk to the legal systems of the country and say, hey, can we make this thing a criminal offense or something like that? But without data and these statistics on paper, we are not able to do that. So for us to advocate for rather against this, and for us to change policy, and for us to have even some laws and such, as far as IOM is concerned, it's very hard because we do not have data on the same. I was surprised when I went through the National Oral Health Survey of 2015, and IOM was nowhere to be seen. And the reason as to why this came as a surprise to me is because this survey was conducted in areas that practice IOM, like Machakos, Kisumu, Garissa, and such. So I was wondering, why is it that we missed out on this? I thought this would be a basis for, engaging the authorities to make this a criminal offense, but it was missing. And then Professor has talked about our involvement as dentists. I say our because I always say I'm a doctor by association because I'm working with doctors every other day. And he's talked about a lot that dentists can do. And I want to add to that by saying that we need more mouths talking about IOM. Like wherever you are, where you're working, you have a community around you, spare some time, talk to them, encourage them, tell them, this is not good, this is what causes diarrhea, and such kind of things. And then I have not gone through the training, or rather the curriculum for cohorts training. And we have these guys in the communities. They are manning dental clinics in some of the counties, and they are very, very critical in the fight against IOM. If only they were, educated more on the same to understand the technicalities around it and all that. So I think this is something that we can also do. And in extension, we can also reach out to other medical practitioners to be aware of this particular practice. Because if a child visits a clinician today and the mother just says, hey, my child has diarrhea, you see, that's just that. They will not be knowing of this particular practice. And then the other thing that I want us also as medical practitioners, and especially the dentists, to look at is the oral health content we have in our primary school curriculum in Kenya. It is so wrong. We have a lot of things in those books that do not actually teach the truth on oral health. And I'll just give you an example before I show you the clip that I have as I conclude my brief presentation. These are photos taken from the current syllabus textbooks that we're using right now in primary school. Going through it, you will realize that we have serious problems. This is what the teachers are teaching. When we meet at the training sessions, we tell them, for example, that in the milk dentition, we do not have premolars. And this pulls a serious fight because they say, no, this is what we've been teaching for the year. For all these years, it must be wrong. Like what you're telling us is wrong and things like that. So I'm appealing to us as dental practitioners also. Please spare some time and scrutinize the content that we have in the textbooks that are in use in Kenya. Because if these kids get wrong information at, say, the ages of 12, 13 and below, they may keep that for a very long time. And the other thing is the brushing techniques and a lot of other things that we, or rather, a lot of other wrong information that we have in the current textbooks. So that is another way, friends, through which you could help us. At this point, I would want to share two images. Professor has given us quite a number, but I have two images that are very, very close to my heart, and I want to share that and bring out something that we are also facing in the community. Those are some of the images that you may have seen, similar images from Prof. I'll just try locating only two that I want us to just briefly look at. And yes, here we go. Good. This image was taken sometime last year, but one from a 17-year-old boy. And as you can see, he doesn't have several teeth here. And the same is also happening on the lower jaw. And this is purely attributed to IOM. Now, this missing teeth thing is very, very, very common in the communities we are working with. Like, so many children do not have canines. I wish we had, some statistics that I report right here, but unfortunately we do not. Now, this one is a girl who visited me. And when she came, she didn't want to open her mouth. She's a Form 3 student right now, a girl. Looking at her upper jaw, she has lost quite a number of teeth. And she's been like this ever since she knew herself in terms of knowing, like, this is the number of teeth that I have. When I talked to the mother told me that, I took her to so-and-so, blah, 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 blah. Look at the lower jaw. That's how she looks like. Now, what am I trying to drive? We have so many children who are suffering also from low self-esteem. So besides the other effects that we've already talked about, IOM would cause this because of the missing teeth, malocclusion, and those other, effects that come about. This girl cannot speak well. She cannot even, dream of becoming, say, for example, a journalist in this country because of the status of her teeth. So it is a serious, serious, serious problem. And my appeal to all of us is that, please, in your community, yes, resources are limited. Yes, we are busy. Yes, we have all these challenges. But please, can we fight this together? I'm sure most of us would wish to join in the fight against IOM, and together we can do more. Allow me at this moment to share with us a video clip. I'm sorry, it has some graphic images, but it will show us how IOM is done, and that will mark the end of my presentation. So let me go. Yes, good.
name is Francis Muthama, the founder and the CEO of Kinga Africa, which is a non-profit organization that was founded to enhance communities' health, particularly oral health, because the need for oral health sensitization and access and affordability of dental services is very, 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 very high in Kenya and in other countries in Africa as well. There is this belief that teething causes diarrhea, and to minimize the effects of diarrhea, the communities have devised their own ways where they extract the developing teeth buds using some crude weapons and, in very, very sterile conditions, and this inflicts a lot of pain.
Oral mutilation is a practice widely accepted and admired among the Kamba community and other African tribes, though not widely talked about. It is locally known in Kamba dialect as kumiaini, translated directly as removal of false teeth or plastic teeth. Strong cultural beliefs or indicate that the unerupted milk teeth, also referred to as any plastic teeth or nylon teeth, are main causes of persistent fever, vomiting and lack of appetite. It is also believed that certain worms in the gum cause diarrhea and that must be removed, a belief doctors dismiss as baseless and without proof.
The parents think that children diarrhea because of teeth problems, but really it's not because of teeth problems. The diarrhea is because of hygiene issues when the child is teething, but not necessarily caused by the milk teeth. So what happens is that they actually gorge out the teeth that are about to erupt in the child's mouth, and we've had cases of reporting that this practice reduces diarrhea in children. So it's a very common practice. It has been going on for ages, mostly in the eastern and the northeastern parts of our country. And the biggest problem is the fact that the children are subjected to a lot of pain. One, the medicine men don't use hygienic measures to be able to take care of these children, to be able to do these procedures on these children. So they don't glove up. They use instruments that are crude. They use bicycle spokes, they use crude knives and crude, even the spoons, they hit the spoons and twist them so that they're able to gorge out the baby's teeth.
In Masinga sub-county, Machakos County, 4 children have been reported to have contacted HIV/AIDS in relation to the exercise. Doctors say that their parents had tested negative, but the tragedy occurred after they took their children to a traditional healer for the removal of a plastic teeth. Actually, when a child shows symptoms of dizziness, lack of appetite, vomiting, fever and diarrhea, a traditional healer is consulted to remove the teeth buds, believed to be the cause of the illness. The village traditional healer notes the swelling in the areas corresponding to an erupted canines that look paler than other parts of a jaw ridge and relates this to the cause of a child's illness. In most instances, the lower capids are extracted bilaterally, but the extracting and lower incisors has also been reported. It is traditionally is done by old men and women healers who are also the beneficiaries of a trade, for it is the main source of livelihood, being paid in cash. Surprisingly, the payment is sometimes a peanut, with some paying 30 or 20 shillings per child. But the myth behind the practice leaves a lot to be desired. It is a belief that whenever a bone is broken, a blood is shed, and that the spouse must not engage in sexual intercourse for a duration of 4 days to ensure a quick recovery. The child should never be touched by a stranger for those 4 days, as breaking those rules can lead to the death of a child and bring a bloodshed curse to the entire family. The instruments used are often not sterilized and no tropical anesthesia is used. Among the Kamba, salt, sodium carbonate in form of soda ash and herbs are applied to the area of a gum that is injured during the process without observing hygienic measures, thus exposing the child to new related diseases. And in the areas have been exposed in contacting HIV and AIDS, there's a need to total campaign in order to control the mass and completely stop the practice. Doctors aver that the practice affects the development of permanent teeth and is the main cause of crooked teeth grows on top of the teeth. The pain the children go through cannot be overemphasized, and as a result, the illness is stopped due to the pain and not due to IOM, as many believe. They also claim that they can't afford to pay for the medical treatment in those health institutions, and that's why they prefer going to traditional healers as they're cheap.
Hospitali zina madawa za serikali, lakini ni mbali. Kutoka hapa kwenda Matu ni 200.
Continues to say that this is a dangerous myth. She says that careful medical studies have not found teething to cause fever, diarrhea or vomiting, a poor hygiene does. She also says wrongly ascribing this to teething can delay the diagnosis and treatment of serious infections, sometimes with tragic consequences.
So basically what we're doing is that we are educating teachers at the community levels. We are also training community health volunteers and the community at large, majorly on what really causes diarrhea and leading them to alternative treatment for diarrhea.
Yeah, that's how this thing is done. It's very sad that it's happening at such a time as this. And at this point, I would just want to say thank you very much for having me on this platform. It's been a very, very, very nice thing. Thank you, the Association of Pediatric Dentists, Nick and your team. Thank you for organizing this. And I would also want to thank Professor for the good work that he's doing in the fight against IOM. Dr. Alice Wageshi, Dr. Opondo, Dr. Faith Kilonso, our chair. It's really, really, really been a good thing that you're doing. Keeping up. And to the rest of us, let's join in the fight. Together we can do this. Thank you very much.
Thank you, Mr. Muthama. That was quite captivating. I'm sure our audience appreciated your talk and especially the video, as graphic as it was. But I think it was informative. So I think now we'll go to the question and answer section. We'd like to thank friends of KAPD who have attended the course. We'd like to make a special mention of Professor Osama from Egypt, Professor Morenike and Dr. Bankole from Nigeria, Dr. Constance and Chigenega from Zimbabwe, Professor Masiga from University of Nairobi, together with Dr. Ngesa, the Chief Dentist, Dr. Mureithi, and the Dean of Dental School, Dr. Mutabe. So the first question we had, I think this will be to Professor Kemoli. In your opinion, what is the trend currently of IOM? Is it on the decrease, especially since literacy levels and urbanization are on the rise? Have you noticed any decrease in IOM?
Thank you very much for that. A very good question. The thing is, we are actually lacking a lot of data on IOM. And that's why I have been saying in my talk that we need to change policy, and we can only change policy with the data. As it is now, we are depending on small research works that are being done in small groups. And from those researchers that have, the results that we have seen is that it is more or less average. You don't see whether it is actually increasing. You don't see whether it is decreasing. That is for Kenya. In other countries, like Ethiopia, there is an indication, for example, that it has increased over the years. In some areas in Tanzania, it has shown that it has increased. But in Kenya, because of lack of data, it is very difficult to judge. In Uganda, it has more or less remained average in the 20s. So we need to generate data, and that has been always there. Data is important for us to be able to know the status and to know what to do. As it is, we know it exists. It is showing the fact that it's existing, but that kind of change is what we can't change.
Okay. I think this will be directed to both of you. Is it a failure on the part of the dentist in terms of education, because we've had a question or a comment that maybe we should be responsible in disseminating information, perhaps even to the gynecologists, who are the first, let's say, primary educators for the parents. So is this an option for us to educate gynecologists, perhaps even nurses and pediatricians?
Francis, would you like to give some comment? Then I will give.
Yes, because one, we have very few dentists in the country, as I had earlier said, but we have other medical practitioners who can easily reach the communities where the dentist cannot. So if we could include these guys in the training, supposing we trained all the nurses, for example, every single dispensary in this country will have at least a clinician and a nurse. And those who do have maternity services and such will also have so many other professionals around. So if we could have all these people sensitized on IOM, I think that will go a long, long, long way.
Yeah, I can only add this. The oral cavity is our area as dentists. And where this IOM is happening is within the oral cavity. Now, what surprises me is some of our dentists in this country, in other countries, come from the communities where it is being undertaken. They don't talk about it either. So it means we are failing the society, the community, because we are the ones to begin to talk about, we are the ones to educate the other health professionals about it and ask them to talk about it. So the ones who should initiate the talk are ourselves. And if we can't do that, then we are failing. Because I can see some of us came from there, we have grown with it, we have accepted it, so we think it is okay because it is what our tribes do. But it is harmful to the child. So the ball rests with us.
Is there any legislation that outlaws IOM?
I'm sure the chief dentist is there, but there is none. There is legislation, which is legislation about FGM, but there is no legislation concerning IOM because we have not talked about it. And we don't have data. So if we can generate more data, if we can talk more about it, then we will be able to influence the policymakers and we come up with policies and legislation.
And since this is a public health issue, do you think IOM is a topic that should be discussed in public health, both in med school, in medical school, and in dental school as a topic?
Yes, I think it is, because Francis can bear witness with me that we went to hospital, Matu Hospital, and we asked if they knew, we asked the public health officers if they knew about IOM, and they said they knew. They even had records. They said 7 children had died in the last, I think, 1 week or 1 month, the time we visited. And they told us what their experience is with this problem. And when you look at what I have outlined about IOM, what is happening, how it is done, and the consequences, and what the child goes through, it is a public health issue. And it should be treated as such.
This is to Francis. What areas does Kinga Africa, or the regions in Kenya, does it cover?
We are in Eastern Kenya. We work in Machakos, Makueni, Kitui. We've also done programs in Coast. We've worked in Nyanza. We work also in Western Kenya. We've done a lot in Central Kenya, so we are spread all over Kenya. So anyone probably who's interested in working with us, they can contact me, and we see how we can work together in the regions where the particular dentists are working in.
Okay. And have you engaged any political leaders in advocating against IOM, where the practice is rampant?
We've not done that because one, we are not a political affiliated organization, but when we do have the community campaigns, we invite political leaders. We tell them in advance what we're talking about. Some of them support the same. So we do not involve them mentally. Actually, we work mostly with medical practitioners, but where we need the politicians, we bring them on board, especially when we're having the community meetings. Thank you.
Okay, a second question. Do you think community practitioners doing IOM and who rely on it heavily for their income will have a high influence on their communities? Is it possible to intervene such a practice when it comes with regards to loss of income?
That is a challenge to our work. When we're training the community health volunteers, we also invite the practitioners, I mean the guys who practice IOM to join us. So when they come, to them, it's a job. To others, it's just a service they're rendering to their communities. So we do not target them mostly. We target the communities because these practitioners will not go house to house looking for the children having diarrhea and such kind of things. They will wait until the community members brings the children to them. So our target mainly is on the community members who take the children to the healers. But now, when it comes to talking to them, we educate them. I remember in one meeting that I'll never forget, we invited 7 of them. And when we played a clip like the one that we just played here, some of them were crying. And I'm like, hey, why are you doing this? Why are you crying? And to other people who do it, you know, when it's played back to them, to really, really hit them very hard. And they vowed to stop this kind of practice. But now we need, as practitioners and as Kinga Africa also, and the other associations to educate and sensitize the communities against this so that they do not take the children there. Whether the practitioners are earning money or losing income or such, then I think the child will come first. Thank
you. Is there a role for social media when it comes to the fight against IOM, such platforms like Facebook, Instagram? Is this perhaps a forum that dentists and maybe oral healthcare workers can use to educate, disseminate information?
Yes, I would say it is. It is. On my part, I would say it is, because it is one way of getting information to the community and also educating the community so that they can understand what IOM is and what it is causing, particularly if those who do not come from those communities who will see that such information can talk to their counterparts from those communities and show them they do not do it and their children are healthy. And that can influence the community. One way of doing so. Mm-hmm. Yes, Francis, you can say.
I wanted to actually support that idea, but the information that will be sent out should be targeting the people who can access this and giving them information on how to reach out to the people in the villages, because some of these people who are learned and people who are in social media do not even know what happens. I was in a community where I was being told that the grandmother will call the son or the grandson from Nairobi and say, are you guys doing well? But so and so has diarrhea, blah, blah, blah. Bring the child home. So they take them there. The grandma takes them to the ELA. So the person who can access social media may not be very, 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 how do I put this? He may not be the very right person to benefit from that information, but they can be very key people in disseminating the same to their communities around them. So social media is a good thing.
With the current closure rules, especially with regards to the COVID-19 situation, is there a plan right now for continuity as far as fighting IOM is concerned?
That's for Francis.
Francis?
Sorry, I missed the question.
Now, the question was, currently the schools are closed. So is there a plan perhaps maybe for Kinga Africa to promote or to continue with a plan for fighting IOM?
We've been having talks around this because right now, as you're saying, we cannot access the schools. The children are also locked in their families and we cannot meet them in churches and other community meetings that we do have. But as of now, we've not come up with a clear plan on how to handle this. It's work in progress. This pandemic came as a surprise to most of us, so we looking into it. We were hoping that maybe the situation would normalize soon, but now that it's not, we are having discussions around that.
Okay. So we also have community oral health officers, the cohorts. Is there a role for them fighting and eliminating IOM?
I think they have a great role in doing so because they are actually trained to work in the communities. And they are the people who have got a better access to the community. When they are going to the communities to talk about oral health, how to brush, what to do in case of pain and so on, they should also be the people to talk about IOM and its effects. And they should be the same people to advise the mothers of young children to take their children to hospitals instead of taking them healers. And they should be the same people to talk to the community leaders to help in stopping IOM in their communities. So I think they are the right people. In addition to the dentists also, who should be part of that community work.
Another comment is that IOM is very common in Nairobi, especially in Kibra, where some parents believe that this practice is normal, and some of these parents are even CEOs of great companies. So the question is, if we see as dentists, or we see a case that has IOM, where can we report such cases to build up data that you mentioned?
Oh yeah, that's a very important question. The best place now would be the KAPD because we still don't have a database somewhere, or to the pediatric dentist, and the pediatric dentist will know what to do. So I think, as the questioner has rightly put it, we need to put some mechanisms in place in terms of how to help these children.
Okay, another question was, with regards to IOM, by definition, does it solely refer to the removal of the canine tooth bud, or practices like uvulectomy and other measures that can occur in the oral cavity?
Yeah, it encompasses all those, by the way, because we have linked the removal of the canine, the primary canine, to be the IOM, because it is the most common and the one which is widespread. But any practice that is involving trauma within the oral cavity will obviously be an IOM issue. Like uvulectomy will be an IOM issue. But because those ones are rarer, they have not gotten the prominence, but they belong to the same group. Yeah. Including even what I described as the trauma, which is the lips are subjected to, it's still within the IOM. Yeah.
So I think our role, the dentists need to play a role with the community health workers, and maybe we can integrate education very early at primary health care level.
Yes, the dentist, as we say, they has a role. You know, in our setup, we have failed to do one thing: how to get our information to the other professionals who are involved with the children. Because we should be able to mingle, interact, and have educative sessions with the pediatrician, for example, with the public health people, and the gynecologists, as you say, because that's the starting point. When you are dealing with the children, you are going to have these people involved. And if they can be educated to know what to tell the mothers about the future of the child, including not to put the child through IOM, it will be the most helpful thing to the child. So we should find ways and means of getting these other professionals coming together, maybe in sessions like what we are having, for them to listen to, and then be able to get educated in knowing there is the existence of IOM. It is traumatic to the child, and it causes this kind of effects in the child, and that the mother needs to know. So that's one of the areas we need to work on in future.
Another question, or maybe a comment, perhaps that can be addressed by both KAPD and Kinga Africa. Is it possible to have posters distributed in county hospitals discouraging or informing people about IOM, role of posters in county hospitals?
Okay, yeah, just go on.
Yes, it's possible. We've done that in Machakos. We've done the same in Makueni. We've even pinned posters in schools and other community centers where we feel people meet. So it is possible. We can actually come together. Now that this is coming up like this, we can join hands and come up with materials that we can distribute within the hospitals and other institutions. So it's possible. With your guidance as an association and the other partners around us, we can do that.
Yeah, just to add on that, it's one of the things we talked about in the Addis Ababa meeting, and the dental officers were in agreement that they would help in developing posters that could be distributed in the clinics, or use their position to have posters developed so that these posters are informative and people can easily see them in clinics and in schools and so on, so that they can learn something about IOM. And I know it's something we've talked with Miriam here, but I know there are, of course, some stumbling blocks in terms of finances and so on. But I think it's the future. We need to have such posters and distribute them in areas where IOM is right.
A follow-up to the question about educated mothers or educated parents. How do you recommend how do we fight years of tradition with someone who's educated and they know that this causes diarrhea and there's no convincing them it doesn't? How do you change behavior and attitude and years of tradition?
Okay. In this regard, I know it's about a mindset, it's about traditions and practices. So what happens is that in communities where this is done, it doesn't seem to have a bearing with education. Even the ones who are educated, you find them taking their children for them to undergo the practice. But you realize these people were born in these communities. They have believed in the traditions and the culture of this community. And when somebody is threatened that if this child does not undergo IOM, is going to die, they obviously become apprehensive. So you find education plays very little within these people from these communities. Even the most educated who have migrated to London, to where they still will bring their children to have IOM done and go back. And that's what you are seeing in the Somali groups, where IOM was existing in the Somalis in the UK, even though it is not permitted by law in UK. So it plays very little in terms of the people from the communities. So they still need education equally, whether they have gone to school or not.
Out of observation, is there a reason why it's the canine that causes diarrhea and not the incisor or the molar? Why specifically the canine?
I think it's because of the anatomy, because the canine is very prominent. So when it is, the budding canine is growing and developing, you know, in that area, it will look like a bulge as compared to other areas because it's the most prominent. And that's why they chose that area, because of the bulge, which they think it is harboring the worms that are causing the diarrhea. So it's just the anatomy.
Okay, I think that's it for the questions. Thank you very much for attending the presentation. Thank you, Professor Kemoli and Mr. Muthama. This was very enlightening. In fact, from the comments, many people have enjoyed this. Follow-up questions can be emailed to the panelists, and we'll get back to you. CPD points will be sent shortly, maybe within the next 3-4 weeks. And any other following question, you can always ask us, and we shall get back to you. Okay.
Thank you very much. Yeah, thank you.